anatomy and blood flow. So the first important function of kidneys, as we all are aware of, is excretion of metabolic waste products, foreign chemicals, drugs, and hormone metabolites. Okay, so which are these waste products? Usually they are the products of metabolism, such as urea, creatinine, uric acid, and bilirubin. Then there are several toxic and foreign substances which also need to be excreted out of the body, and those are mainly pesticides, drugs, or food additives. The second function is regulation of water and electrolyte balance. So basically, the kidney has a huge capacity to make alterations in sodium excretion, and that depends on the kind of sodium intake a person has. Okay, and similarly, again, it has an ability to alter its function of being able to excrete water and electrolytes, and this also depends on the kind of intake a person has done. And what are these electrolytes that I'm talking about? Mainly chloride, potassium, calcium, hydrogen, magnesium, and phosphate ions. Then kidneys have a very important role in regulation of arterial pressure. So they are involved both in the short-term and long-term regulation. Right now, I'm only enumerating the functions. As the further lectures happen in the excretory system, you will learn the mechanisms of each of these functions. So don't worry at this point of time. We are just enumerating the functions, okay? So the regulation of arterial pressure occurs by means of long-term regulation. That is by excreting variable amounts of sodium and water by the kidneys. And in case of a short-term regulation of arterial pressure, this is done by secreting hormones and vasoactive substances like renin, which further leads to formation of vasoactive products like angiotensin II. Okay, so these two have an important role, renin and angiotensin II, in the short-term regulation of arterial blood pressure. And as I said, you will learn all about it in the later chapters. Then the fourth function is regulation of acid-base balance. So again, you have an entire chapter dedicated simply to the acid-base balance of the renal system. So again, you will learn this in detail. For now, just know that this acid-base balance is done by two basic means. One, controlling bicarbonate excretion, and secondly, by controlling hydrogen secretion. So in both the cases, the renal system controls the blood pH and the pH of body fluids by secreting these two ions, secretion and excretion of hydrogen and bicarbonate ions. Then another important function is regulation of RBC production. So the strongest stimulus for RBC production is hypoxia. And hypoxia leads to erythropoietin secretion by the interstitial cells in peritubular capillary bed of kidneys. Now, that erythropoietin secretion stimulates the production of RBCs. And that is why in many patients who have a renal disease, you will find that they are often anemic because of the same reason that the RBC production is hampered. Then production of active form of vitamin D. So whenever we consume the dietary sources of vitamin D3, the first hydroxylation takes place in liver, okay, and after that it is converted into 25-hydroxycholecalciferol. Now the second hydroxylation occurs in kidney, Okay, and by that we get 125 dihydroxycholecalciferol, also known as calcitriol, and it is this form of vitamin D, the calcitriol, that acts in intestines to increase serum calcium and phosphate concentration. So again, a very important role played by the kidneys in the second hydroxylation of dietary vitamin D3. Then glucose synthesis. So you may have generally heard that if there is a situation of prolonged fasting or starvation in the body, we generally learn of the body making glucose from other sources, like amino acids or other precursors, which is also a process called as gluconeogenesis. But we have often heard that is mainly done by the liver. But kidneys have a very important, they are very important contributors for doing the same process, and nearly as much as the liver. So in such cases, prolonged fasting or starvation, they synthesize glucose from the non-usual sources like amino acids and other precursors. This process, as you know, is called gluconeogenesis, and this adds the glucose to blood. And so that's why, again, in kidney disease, you will have not just electrolyte imbalance, but again, issues with control of blood sugar. Then endocrine function. So I just mentioned to you the secretion of renin, which activates your renin-angiotensin system involved in control of regulation of arterial pressure. And we just spoke about formation of calcitriol, which I mentioned happens because of the second hydroxylation of dietary D3. So these two, and of course, then I also mentioned the secretion of erythropoietin, right, which was stimulating the RBC production. So in addition to erythropoietin, there's also secretion of thromboxane A2 and prostaglandins. So all these come under the endocrine function performed by the kidneys. Then regulation of ECF volume and plasma osmolality. So for ECF volume, extracellular fluid volume, the hormones involved are aldosterone, ADH, ANP, and angiotensin. They act on kidney tubules, they reabsorb sodium and water, and that's how the ECF volume is controlled. In case of plasma osmolality, ADH has a major role. Again, it acts on kidney tubules. It controls sodium chloride and water reabsorption, and this is how the plasma osmolality is regulated. So that's all about the functions of kidney. Now next we will go on to the anatomy, the gross anatomy mainly, and about the blood flow. So just give me a second to get to the other PPT. Okay, so now we are going to talk about the functional anatomy and blood flow. Okay, so first of all, let's talk about the external features. So where are the kidneys located? Kidneys are basically bean-shaped organs that lie retroperitoneally on posterior abdominal wall, one on each side of the vertebral column at the level of T12 L1 vertebrae. The right kidney lies slightly inferior to the left kidney. So now we know the location of the kidney. Let's go on to the size and shape. During lifetime, kidneys are reddish brown in color. Each kidney in an adult human weighs about 150 grams and measures approximately 10 centimeters in length, 5 centimeters in width, and 2.5 centimeters in thickness. Now, each kidney has an anterior and a posterior surface. So here you can see they have shown the anterior surface. Then it has medial and lateral margins. So somewhere around here would be the medial margin, this would be the lateral margin, and superior and inferior poles. So this is your superior pole, inferior pole. The lateral margin, as you can see, is convex, and medial margin is concave, where the renal sinus and renal pelvis are located. So this is your renal pelvis. Then a little bit about the renal hilum and sinus. So the renal hilum is a vertical cleft present on concave medial margin. It is the entrance within the, here, this is the hilum. It is the entrance to space within the kidney. That is the renal sinus. Okay. So through the renal hilum, the renal artery enters the renal vein, and renal pelvis, they leave the sinus. So through this area, your artery enters, and your renal vein and the pelvis, they leave the hilum. Renal vein and ureter leave the hilum. So renal sinus is thus occupied by renal pelvis, calyces, vessels, even nerves, and a variable amount of fat. Then what is your renal pelvis? It's basically a flattened funnel-shaped expansion of superior end of ureter. So your ureter is beginning here, but this is like a flatter part of the ureter, which we called as the renal pelvis. It's kind of funnel-shaped expansion. Okay, and with, as we said, within the renal sinus, the pelvis divides into 2 or 3 parts called as major calyces or the minor calyces. So in this diagram, you might be able to appreciate. See here, now this renal pelvis has divided into 2-3 parts. The broad parts here, this one and this one, is your major calyx, and then the smaller branches of it, these are the minor calyces. Now each end of the minor calyx is shaped like a cup into which projects the kidney tissue called as renal papilla, or the apex of renal pyramid. So you see these are all pyramids here, okay? And these pyramids have a base and an apex, right? And the apex is fitting into this cup-shaped projection of the minor calyx, okay? And these, the apex of the pyramid is called as the renal papilla. Okay, here they've shown renal papilla. Here, do you see that this is the hilum, and this is where the artery enters and the vein leaves? Again, all from the hilum, and the ureter also starts from, leaves the kidney from the same hilum. Okay. So that's about the gross anatomy. Now let's go on to the internal structure. So the kidney tissue consists of an outer region called as the cortex. This is the cortex. Okay, and then an inner region called as the medulla. So as I said, the medulla is made up of triangular areas of renal tissue that are called as renal pyramids. They're usually 4 to 14 in number and separated from each other by cortical columns of Burton. So here, these would be the, in between the pyramids are the cortical columns of Burton. And as I mentioned earlier, each pyramid has a base directed towards the cortex and an apex, what we also call as the renal papilla, which is directed towards the renal pelvis. And of course, this renal papilla or the apex of the pyramid fits into the minor calyx. Okay. Now these pyramids, they usually show striations, okay, that pass radially towards the apex. Okay, these striations are due to a straight portion of nephron and extend some distance towards into the cortex, where they are called as medullary rays. So these striations which are towards the cortex are called as medullary rays. Then the medulla can be subdivided into two parts: outer medulla, which is further subdivided into outer stripe and inner stripe. I'll just show that. I think that's in a different diagram here. So here you see that this is your cortex, and the outer medulla and inner medulla, and the outer medulla is divided into two parts: the outer stripe and the inner stripe. And the inner medulla is also called as the papillary zone. Okay, now coming back to cortex. Now the renal cortex can be divided into two parts which are continuous with each other. The cortical arches or the cortical lobules refer to tissues lying between bases of pyramids. So here the tissue lying between bases of pyramids and surface of the kidney. So these are the cortical arches or the cortical lobules. Okay, and then the second part would be the renal columns, which we spoke about earlier, and that refers to the cortical tissue that lies in between the pyramids. Okay, so these are the two parts of the cortex. And the lobe of kidney, basically each pyramid is surrounded by a shell of cortex, and that constitutes the lobe of the kidney. So this would be a lobe of the kidney, for example. This would be another lobe. Okay, each pyramid surrounded by the cortex. Okay, let's go further to the microscopic structure of kidney. So now the cortex and medulla of each kidney are composed of nephrons, blood vessels, lymphatics, and nerves. Now, nephron is your structural and functional unit of kidney. There are about 1.2 million nephrons per kidney, and each nephron is capable of forming urine. So now let's go on to the structure of nephron. The nephron consists of two main parts: the renal corpuscle or renal tubule. So first, let's talk about the renal or the Malpighian corpuscle, as it's also called. It is a rounded structure comprising of a glomerulus, okay, surrounded by a glomerular capsule. Now, what is your glomerulus? It's a rounded tuft of anastomosing capillaries. The blood enters the glomerulus through an afferent arteriole. Okay, then here is your tuft of capillaries, and then it leaves it through an efferent arteriole. Okay, and please remember, an efferent arteriole, an efferent vessel is an arteriole. Okay, it is not a venule, so please keep that in mind. Then we have a glomerular or a Bowman's capsule. Okay, and this capsule is the one which encloses the glomerulus. It's formed of two layers. Okay, one is the inner layer covering the capillaries. Here, if you see this thin layer here covering the capillaries, this is known as your visceral layer. Okay, and then you have an outer layer which is known as the parietal layer. Here, this is the outer layer or the parietal layer. Now, in fact, the Bowman's capsule, it represents a cup-shaped blind end beginning of the renal tubule. See here, this is where your proximal tubule begins. And now the space between the visceral layer And this parietal layer is your Bowman's space. Okay. Then mesangium is also an important component of the corpuscle, and it consists of mesangium cells that are present between capillary endothelium and basement membrane. We'll just go on to that. And these cells basically provide a structural support for these glomerular capillaries. They secrete extracellular matrix and exhibit phagocytic activity. So now let's go on to the ultrastructure of the glomerular membrane, or what is also known as the filtration barrier. So glomerular membrane, it refers to the membrane that separates blood of glomerular capillaries from fluid present in the Bowman's space, and therefore it is also called as a filtration barrier, and it consists of three main layers. What are those? So first is capillary endothelium. Here, this is your capillary endothelium. It is fenestrated. Okay. And what that means is that it contains pores with diameter of 70 to 90 nanometer and are freely permeable to water, to small solutes, and even to small proteins. Then you have the basement membrane. It consists of a matrix of glycoproteins and mucopolysaccharides. As compared to a typical membrane, the glomerular basement membrane is very thick. Okay, generally, as compared to other membranes, this one is quite thick. It comprises of three layers here, which I mentioned. Lamina rara externa, or the outer cement layer. Then the middle layer is lamina densa. And then the inner layer is lamina rara interna. And no pores so far have been demonstrated in the basement membrane. However, its permeability corresponds to pore size of about 8 nanometer. So this is your second layer, basement membrane. Then coming to the third layer, Bowman's visceral epithelium, or inner layer of Bowman's capsule, which forms the third layer of glomerular membrane. Now this is formed by special cells called as podocytes. Okay, this is a very characteristic of the filtration barrier. So your podocytes have basically finger-like processes which encircle the outer surface of the capillaries. And these processes of podocytes, they interdigitate to cover the basement membrane here and are separated by gaps known as filtration slits. Okay, in between them. These are of approximately 25 nanometer diameter, and each filtration slit is covered by a layer of fine filaments that constitute the diaphragm. Okay, so these are the podocytes with finger-like projections. They are covering the basement membrane, and in between them are the filtration slits. Then let's talk about the renal tubule. So it's a long, complicated tubule. It has four main parts. So first is your proximal convoluted tubule, or what we call as the PCT. Okay, here you can see the PCT. So it initially forms several coils. PCT is usually followed by a straight segment, a pars recta, or a proximal straight tubule that descends towards the medulla. So initially you see these coils, and then there is a straight segment which is going towards the medulla, which is known as the proximal straight tubule or the pars recta, the straight portion. Then we have intermediate tubule, or what we commonly call as the loop of Henle. Okay. Now the loop of Henle has three parts. So one is your descending thin limb, okay, which I've referred to as DTS. Then you have the ascending thin limb or the ATS, and here then you have a thick, you can see that better in this nephron actually here. This is your thick ascending limb or the TAL. So in this particular nephron, this is your descending thin segment, ascending thin segment, and your thick ascending limb, the TAL. Okay. Then we have the DCT. Okay. So DCT begins a short distance beyond macula densa cells. Okay. This is your DCT. And extends to a point in cortex when connecting tubules of two or more nephrons join to form a cortical collecting duct. So once your loop of Henle finishes, okay, including the ascending limb, then starts your DCT, and then it goes on to form the cortical nephrons, cortical collecting ducts. Okay, so the cortical collecting ducts are usually formed by connecting tubules of two or more nephrons, as you can see here. So see, you can see more tubules are joining in here from more nephrons to form a common collecting duct. Okay, so your collecting duct has three parts mainly: the cortical collecting duct, which we just talked about, the CCD. Then there is a outer medullary collecting duct, okay, outer medullary collecting duct, and then there is a inner medullary collecting duct. So this is present in outer medulla, and the inner medullary collecting duct is present in the inner medulla. And then several in inner medullary collecting ducts, they coalesce together to finally open at the tip of renal papilla. So you see this point, at this point, several other medullary collecting ducts will coalesce, and right at the tip of renal papilla, this will happen. Then some characteristics of the epithelium lining the renal tubule. So basically, this epithelium has some special characteristic features which are suited to perform some specific transport functions. So the type of cells lining the renal tubule are mostly cuboidal, except in thin segment where they are flat or squamous. So you have the apical surface. The apical surface of cuboidal cells bears a few microvilli, okay, in general, which are numerous, dense, and amplified in the PCT cells to form the brush border. So these are your microvilli which have a brush border appearance, okay, on the apical surface of the renal epithelium. Okay, then you have a basolateral membrane. This is your basolateral membrane of proximal convoluted of the PCT cells, and this is present in thick ascending segment and also in DCT cells. It's highly invaginated. If you see, look at these infolds, okay, and contains many mitochondria. These infoldings create basal spaces, as you can see here. And in contrast, the cells of descending thin limb and ascending thin limb of loop of Henle, they rather have poorly developed basolateral surfaces and contain fewer mitochondria. Then you have the lateral surface. So this was the apical surface. This is the basolateral surface. And then here is your lateral surface of renal tubules, okay, which bear a lateral cell process. And they interdigitate with lateral processes of adjacent cells. Okay, so these are the interdigitations. This is your lateral intercellular space. And the lateral intercellular spaces, they don't communicate with basal spaces. So as you can see, they are quite different. These are your lateral intercellular spaces and these are your basal spaces. There's no connection here between the two. And then the lateral surfaces also form two types of tight junctions, as you can see here. So one is a leaky tight junction that does not permit water and solutes to diffuse across them easily. Okay, this is more characteristic of a DCT cell. Okay, in a PCT cell. And then you have tight junctions that don't permit water and solutes to diffuse across them easily. These are characteristic of a DCT cell. Okay, then your cortical collecting duct is also composed of two kinds of cell types, which we'll talk about later on also in detail. So one type of cells are principal cells. They have a moderately invaginated, again, basolateral membrane and contain fewer mitochondria. And the intercalated cells, they have a high density of mitochondria. That is the difference between these two cells. And then your inner medullary cortical duct, it is composed of a single layer of cells that have poorly developed apical and basolateral surfaces and a few mitochondria. Okay, so this is about the epithelial lining of renal tubule. Now, this is an important question that you often get in exams, or you may even be asked in your vivas. That is the difference between cortical and juxtamedullary nephrons. So if you can have a look at the juxtamedullary nephron, the DTS, okay, the descending limb, it joins the ATS to form the ascending thin limb to form a loop, a pin band loop. This is the loop. Okay, so you have a distal, the descending limb, and in between the ascending limb, you have this hairpin band loop. Okay, and then the ascending thin limb, it reaches up to the junction of outer and inner medulla. Okay, and then in case of cortical nephrons, the descending thin limb is continuous at the bend of the loop with a thick ascending limb, which I showed you earlier. So here both were thin, the descending limb also and ascending limb also, but here the descending limb is thin, but the ascending limb is thicker, known as a thick ascending limb, TAL. And near the end of TAL, the nephron passes between the afferent and efferent arteriole. Okay, so as your thick ascending limb is finishing, the nephron passes between the afferent, very close to the afferent and efferent arteriole, and that place where it passes very close by forms the macula densa, which we'll talk about very soon. So basically, these are your two types of nephrons. The cortical nephrons, the name itself says that they are basically, most of their portion is in the cortex. And then the juxtamedullary nephron, most of the portion of these lies in the medulla. These are almost about 80 to 85% of the nephrons are cortical nephrons. And another main difference I told you is that thick ascending limb is present in cortical nephrons, not in case of juxtamedullary nephrons. Also, What you find, another change, another difference between the two is here the cortical nephron is surrounded by the peritubular capillaries, which you see. But here you have vasa recta. The capillaries are sort of moving parallelly to the loop of Henle, if you see. So this is your vasa recta. Okay, so broadly, these are the differences between the two kinds of nephrons. And this is an important question. See, this is a chart showing all the differences. So the glomerulus is mostly in the upper region of cortex. In this case, it's near the junction of cortex and medulla. Then I told you these are nearly 85%, 15% JMN, the juxtamedullary nephrons. The size of glomeruli are small in case of cortical nephrons. They are larger in case of juxtamedullary nephrons. The loop of Henle is also small and extends up till outer layer of medulla. Here it is larger, longer, extends deep into the medulla. I told you the descending limb is the same for both. They have thin segments, but the difference lies in ascending limb. Your cortical nephron has a thick segment, but your juxtamedullary has a thin segment. Then the efferent arterioles here, they have large diameter and break into the peritubular capillaries. I showed you here. This network of capillaries is the peritubular capillaries in case of cortical nephrons. But the efferent arterioles in case of juxtamedullary nephrons, they have smaller diameter and they continue as vasa recta here, moving parallelly with the loop of Henle. Then the rate of filtration of cortical nephrons is slow, whereas that of the juxtamedullary nephrons is faster, higher rate. And this is an important thing. The cortical nephron is mainly concerned with excretion of waste products in urine, but the juxtamedullary nephron, apart from excretion function, its main job is concentration of urine by the countercurrent system. Again, something we'll talk in detail in the next few chapters. Then this is, again, I would say a very important question from this chapter. A note on juxtaglomerular apparatus is very much expected. So the juxtaglomerular apparatus, or the JGA, is a collection of specialized cells located very near to the glomerulus. It forms a major component of the renin-angiotensin-aldosterone system, which I referred to when I was talking about the regulation of arterial blood pressure by kidneys. So now your JGA comprises mainly of three kinds of cells. So first is your juxtaglomerular cells here, which you can see. So these are your specialized myoepithelial, or what is also basically the modified vascular smooth muscle cells. Okay, so these are your JGA cells located in the middle of afferent arteriole in region of JGA apparatus. Okay, here. So these are your JGA cells. Now they have some characteristic features that we all should know. They have well-developed Golgi apparatus and endoplasmic reticulum, abundant of mitochondria and ribosomes. Okay, they synthesize, store and release an enzyme called as renin. Remember we talked about renin as part of both regulation of arterial blood pressure and as a endocrine function of kidneys. So that renin is synthesized, stored and released here itself from the JGA cells. Okay, the manufactured renin is stored in secretory granules of these cells. Okay, and hence they are also known as granular cells. Now, very, very important thing about the JGA cells is that they act as baroreceptors or tension receptors. Okay, and they respond to changes in transmural pressure gradient between afferent arterioles and the interstitium. So basically, JGA cells are baroreceptor cells. That's their most important function, I would say. They are densely innervated by sympathetic nerve fibers and release the renin content in response to sympathetic discharge. Okay. Also, because these cells act as volume receptors, vascular volume receptors, they monitor renal perfusion. Okay. And granulation of and are stimulated by hypovolemia or decreased renal perfusion pressure. So basically, because they are baroreceptor cells, they are sensing, they are volume receptors itself, so it's their job to monitor renal perfusion. So whenever there is hypovolemia or there is decreased renal perfusion pressure, they will come into action. They will get stimulated and release renin, and then the whole process will start. Granulation of these cells increases whenever there is sustained hypotension in an afferent arteriole. For example, that can happen in a sodium deficiency. Okay, so when they are stimulated, the granulation will increase, which means that renin secretion and storage will increase, and then based on the sympathetic nerve discharge, renin will be secreted into the system. Then second very important cells are macula densa cells. So these are also now specialized renal tubular epithelial cells. Here, these are the macula densa cells. And they are present in cells of short segment of thick ascending limb of loop of Henle. I just referred to them when I was talking about the juxtamedullary nephrons. And they are between the afferent arteriole and efferent arteriole. So you can see this is your afferent arteriole, efferent, and this entire structure is lying in between them, including the macula densa cells. Now again, these have some important characteristic features. They are not well developed for reabsorption. They are not innervated also. These cells are in direct contact with the mesangial cells and in close contact with the JGA cells. So here they are quite in close contact with the JGA cells and also with the mesangial cells. Okay, and now the most important characteristic about them is that they act as chemoreceptors. Okay, they are stimulated by decreased sodium chloride concentration, and they also therefore cause increased renin release. Okay, so remember that juxtaglomerular cells were acting as baroreceptors, whereas your macula densa cells act as chemoreceptors. Okay, these are stimulated when there is sustained hypotension, for example, in case of a sodium deficiency, and these are stimulated by decreased sodium chloride concentration, and both are basically causing release of renin. Okay, then you have mesangial cells or the lacy cells in between these two. Okay, these are the interstitial cells, and the characteristic features about these are that they are in contact with both your layers of cells, which we just talked about. See, right in the middle. And functionally, these cells, they possibly relay the signals from macula densa to the granular cells after modulating the signals. So basically, they are just kind of being messengers, okay, and sort of doing the communication between these two cells. Okay, and a decreased intraluminal sodium load or a chloride load or both in the region of macula densa will end up stimulating the JGA cells to secrete renin. So that message, whatever fluid is present here, that message will go from the macula densa to the JGA cells through the mesangial or the lacy cells. Okay, and they also show granulation to secrete renin in conditions of extreme hyperactivity. So let's just say that they are like, like a last sort of a reserve, or a extreme situation has arisen, and only then do they play their role of secreting renin. And they also secrete some other substances and take up immune complexes. So this is about your JGA apparatus. Okay, so now let's go on to the renal blood flow and arterial vessel arrangement. So there is a renal artery which is present, one for each kidney. Okay, and it is a major branch from aorta. It divides into number of lobular arteries at the hilum of kidney. Okay, so here, somewhere here would be your renal artery, which is a major branch from aorta, and it divides into lobular arteries. Okay, in lobular artery is present one for each pyramid. Okay, and it divides into two or more interlobar arteries. These are your interlobar arteries. Now the interlobar arteries, they enter the tissue of renal columns and run towards the surface of kidneys. Right? You can see them running towards the surface of kidneys and reaching the level of bases of pyramids. The interlobar arteries divide into arcuate arteries. So as soon as they have reached the base, this is the base of the pyramid, they divide into arcuate arteries. Now these arcuate arteries, they run at right angles to the parent interlobar. You can see they're running at right angles, and they lie parallel to the renal surface. So this is your renal surface, and they are going parallel to it at the junction of pyramid and cortex. So this is your cortex and this is your pyramid base here. And then they give off a series of interlobular arteries here. Okay, now the interlobular arteries, they run through the cortex, and again now at right angles. Again, they are running at right angles to the renal surface to end in a subcapsular plexus. Okay, and so the reason they are called as interlobular arteries is because they are dividing the cortex into the small lobules, which we talked about right in the first slide. And then each interlobular artery gives off series of afferent arterioles. Okay. Now something about the afferent arterioles. So they enter the Bowman's capsule and divide into the round tuft of anastomosing capillaries called glomerulus, which we just talked about. And this capillary network has special features owing to which it acts as a sieve, okay, allowing plasma filtration with retention of plasma proteins and blood cells. Okay, so the glomerular capillaries then join to form the efferent arteriole. So we already talked about that earlier, right? Here. Okay, so ultimately your interlobular arteries, they gave a series of afferent arterioles, then the tuft of anastomosing capillaries called glomerulus, and then into the efferent arterioles. The characteristic feature about these is they act as a sieve, allowing plasma filtration, okay, but they don't let plasma proteins and blood cells normally pass into the filtrate, okay, and then they end into the efferent arteriole. Now let's talk about the efferent arteriole. So now the efferent arterioles leaving the glomeruli of two types of nephrons, they exhibit different behavior, which I had mentioned when we talked about the differences between the two kinds of nephrons. So those from the cortical nephrons divide into peritubular capillaries that surround the PCT and DCT, forming a meshwork of microvessels, and these drain into the interlobular veins here. Okay, so this is the capillary plexus, which I was just talking about. They've shown you a glomerulus of both a cortical nephron and that of a juxtamedullary nephron. Okay, and talking about the cortical nephron, this is the capillary plexus. Okay, and then it will join the interlobular vein. And then the same cycle that we talked about in terms of the arteries, the same branches you have in terms of veins. And now the efferent arteriole in case of a JMN gives rise to vasa recta, which I showed you earlier, running parallel with the loop of Henle. Okay, so they descend with long loops of Henle into the renal medulla and return to the area of glomerulus and drain into interlobular or an arcuate vein, similar to the cortical nephron. And then you can see that there are some side branches also arising from vasa recta, which form a capillary network at different levels along the loop of Henle. So these are the two capillary networks, arising from efferent arterioles of the two kinds of nephrons. And now, as I said, the arrangement of the venous vessels or the renal veins is similar to that of the arterial system, except for presence of multiple anastomosis between veins at all levels of venous circulation. And the corresponding veins which run parallel to the arterial vessels are, again, as was in the arterial supply, interlobular veins, then arcuate vein, then renal vein, which I told you exits at the renal hilum. So now let's go on to the innervation of kidney. So they are innervated by sympathetic and parasympathetic fibers. So the parasympathetic innervation is by vagus, but its function is uncertain. The sympathetic innervation is by pre-ganglionic sympathetic fibers which arise from neurons of lower thoracic and upper lumbar, that is T10 to L2, intermediolateral segments of spinal cord. The cell bodies of post-ganglionic neurons are located in the ganglia of sympathetic chain and superior mesenteric ganglia. The fibers from these neurons are carried by renal nerves which travel along renal blood vessels as they enter the kidney. The efferent fibers are mainly distributed to afferent and efferent arterioles and cells of renal tubule, also to the juxtaglomerular cells. So remember we said about the juxtaglomerular cells that on getting the sympathetic discharge is when they secrete renin. So that's what I just mentioned just now regarding the sympathetic innervation. Then afferents from kidney, whether they are of pain fibers, etc., they run along with efferent fibers and enter in spinal cord through thoracic and upper lumbar dorsal roots. Okay. Then coming to renal blood flow. So renal blood flow has some interesting features that we will talk about. So the rate of renal blood flow under basal conditions is approximately 1200 milliliter per minute. That means around 400 milliliter per 100 grams of tissue per minute. So basically what we are trying to say is that the rate of renal blood flow is very, very high compared to other tissues. The total renal blood flow is approximately 20% of resting cardiac output. While the two kidneys, they are only making, remember, they are making less than 0.5% of total body weight. But the blood flow, as I said, is 20% of resting cardiac output. Now, this higher blood flow to kidneys is in relation to its excretory function rather than its own metabolic needs. So for its own metabolic needs, it doesn't need such a high blood flow, but it's for the excretory function that it does so. In face of blood pressure changes, the renal blood flow shows remarkable constancy due to a phenomena of autoregulation that we'll just talk about. And also, during exercise, sympathetic tone to the renal vessels increases and it shunts the renal blood flow to the skeletal muscles. This is the case in most organs. That happens during exercise when the blood flow is shunted towards the skeletal muscles. Then a word about renal blood flow and oxygen consumption. So again, the renal oxygen consumption, which is approximately 5 ml per 100 gram of tissue per minute, is very high, being only second to the heart. That is 8 ml per 100 gram of tissue per minute in the body. And the arteriovenous oxygen difference, which is approximately 1.5 ml of blood, is the smallest of any major organ system. So the oxygen consumption is very high, but the AV oxygen difference is one of the smallest of any major organ system. The oxygen consumption, or what we also call as the VO2 in kidney, is directly proportional to the renal blood flow. So unlike other organs where blood flow related to oxygen requirements of organs, in kidneys, oxygen consumption is a function of blood flow. Okay, so these are some things which are different about the renal blood flow. Okay. So now your glomerular capillaries, they have relatively high hydrostatic pressure, okay, around 45 mm of Hg, which is an important factor in formation of glomerular filtrate. And your peritubular capillaries have low hydrostatic pressure, which is just around 8 mm Hg due to drop in pressure of efferent arteriole. So this decrease in hydrostatic pressure in the peritubular capillaries basically facilitates reabsorption function of PCT and TCT. The renal veins have a hydrostatic pressure of only 4 mm Hg. And a word about renal portal circulation. So the afferent arterioles arise from interlobular arteries. We know that now. And each breaks up into a bunch of capillaries called glomerulars. Yes. So these glomerular capillaries drain into efferent arterioles, which again breaks up into a peritubular capillary network, and that ultimately drains into the interlobular vein. So in this way, basically, you have two sets of capillaries which are formed. And so this entire renal circulation is, then you can call it as a sort of a portal circulation. Okay. Then the regulatory mechanism, they affect renal blood flow and glomerular filtration rate, or the GFR, by changing arteriolar resistance. Okay. So what happens is constriction of afferent arteriole occurs. This decreases renal blood flow and GFR without change in filtration fraction. I'll just explain to you about filtration fraction also. And dilation of afferent arteriole increases both renal blood flow and GFR, again without change in filtration fraction. Okay. So now I had spoken to you earlier about something called as autoregulation. What is that? So basically, your renal blood flow and GFR, they remain constant over a wide range of renal arterial pressures, which is around 80 to 200 mm of Hg, due to a intrinsic mechanism known as autoregulation. So now there are two basic mechanisms of autoregulation. Okay, one responds to changes in arterial pressure and the other responds to changes in sodium chloride concentration of tubular fluid. So autoregulation is a very important concept of renal blood flow, a very important question also exam-wise. And what it basically means is that even if the blood pressure of a person is fluctuating, okay, but the renal blood flow and the GFR, the kidney manages to keep these still constant as possible, and that happens because of its own intrinsic mechanisms, okay, which is known as autoregulation. And there are two mechanisms, myogenic mechanism and tubular-glomerular feedback mechanism. So the first one, this is related to the intrinsic property of vascular smooth muscle, tendency to contract when it is stretched. So when renal arterial pressure is raised, the afferent arterioles are stretched, which contract and increase vascular resistance. Increased vascular resistance offsets effect of arterial pressure and so maintains a constant blood flow and GFR. So I just mentioned to you just a minute back that the basic control is through constriction or dilatation of the arterioles, okay, whether afferent or efferent. And so in this case, in the myogenic mechanism, suppose the arterial blood pressure is increased, the afferent arterioles will get stretched. That means they will contract and there will be increased resistance. And this increased resistance will offset effect of the arterial pressure. And so again, your RBF and GFR will be maintained. Then your second mechanism is tubulo-glomerular feedback mechanism. Okay, this is based on NaCl concentration of the tubular fluid involving a feedback loop, which operates as the changes in GFR, they cause changes in sodium chloride concentration of fluid in loop of Henle. And these changes in NaCl concentration, they will be sensed by your macula densa cells. Remember the chemoreceptor cells in the JGA apparatus and converted into a signal. Now this signal from macula densa cells changes the vascular resistance in afferent arterioles, which we just spoke about in the myogenic mechanism. And the signals obtained due to an increased NaCl concentration will produce vasoconstriction, and those due to a decreased NaCl concentration will cause vasodilation of afferent arteriole. Now this effector mechanism, which is responsible for the vasoconstriction or dilation, is not exactly known. Perhaps adenosine triphosphate, or what we call as ATP, selectively constricts the afferent arterioles and metabolites of arachidonic acid, which may contribute to the TGF mechanism. So just have a look at this diagram. Here where you have the increased renal arterial pressure. So as we talked earlier, the GFR and the renal blood flow is expected to rise. Now there is increased sodium chloride concentration in the tubular fluid. This is sensed by the macula densa cells, the chemoreceptor cells of the JG apparatus. They give a feedback signal or feedback effect, and there is constriction of afferent arteriole. Okay. So this whole feedback system is formed, and this will prevent some major change in your GFR and RBF value. So keeping it constant in case of increased pressure. Now in case there is decreased pressure, so again there will be now effect on the sodium chloride concentration, which will be decreased in the tubular fluid, again sensed by macula densa cells feedback system, and this time there'll be dilation. So again, it will prevent the decrease of GFR and RBF, thereby keeping them constant in a range of, I told you, 80 to 200 mm of Hg. Okay, this is the range in which this mechanism can operate. So, what is the significance of autoregulation? So, a small change in GFR, okay, has great effect on urinary output and therefore on loss of solutes and water. So, if the RBF and GFR were to change suddenly in proportion to change in blood pressure, okay, if this mechanism was not there and GFR and RBF also changed as abruptly as a person's blood pressure, then the urinary excretion of fluid and solute would also change suddenly or abruptly. And such changes in water or solute excretion without a comparable alteration in intake would be disastrous due to alterations in fluid and electrolyte balance. So for this reason, autoregulation of RBF and GFR is a very effective mechanism for uncoupling renal function from fluctuations of arterial pressure and to maintain fluid and electrolyte balance. So no matter what arterial blood pressure changes are happening in the body, the kidney is able to preserve its basic regulation of RBF and GFR. Then some important facts about autoregulation. So autoregulation of RBF and GFR is virtually absent at mean blood pressure below 80. Okay, I told you it operates only in the range of 80 to 200 mm of Hg. It is not a perfect mechanism, so they do change slightly with variation in arterial blood pressure, but no major change as long as your kidney is healthy. And several other hormones and factors can also change RBF and GFR, even despite the autoregulation mechanisms. So, some other hormones which can actually change GFR and RBF, they include norepinephrine, which causes intense vasoconstriction of both afferent and efferent arterioles. Angiotensin II can affect in low concentration. It can cause predominant constriction of efferent arterioles. However, at high concentration, it causes constriction of both afferent and efferent. And endothelin can cause profound vasoconstriction of both the arterioles. This is secreted by endothelial cells of renal vessels. So these three hormones, norepinephrine, angiotensin II, and endothelin, can cause vasoconstriction and thereby decrease RBF and GFR. And then there are hormones which can cause vasodilation and increase RBF and GFR. Those are prostaglandins, nitric oxide, bradykinin, atrial natriuretic peptide or ANP, glucocorticoids, dopamine, and histamine. So now coming to nervous regulation. So under normal conditions, your sympathetic tone is minimum. But mild to moderate stimulation of sympathetic nerves usually has mild effects on the RBF because of, as I said, autoregulation mechanism again. However, when there is strong acute stimulation of sympathetic nerves, they may produce marked fall in renal blood flow, even up to 10 to 30% of normal, temporarily due to constriction of both afferent and efferent arterioles. And this effect is mainly by alpha-1 adrenergic receptors and to lesser extent postsynaptic alpha-2 adrenergic receptors. This system works to preserve arterial pressure at the expense of maintaining normal RBF in conditions of acute hypotension due to severe hemorrhage. Okay, so in an acute situation, the body takes a call to maintain the normal RBF. Suppose acute hypotension has occurred because of severe hemorrhage. So at that time, the strong acute sympathetic stimulation will come to rescue. Further, an increase in sympathetic activity also increases release of epinephrine and angiotensin II, enhancing vasoconstriction. I just told you that these two hormones are responsible for vasoconstriction and increase, thereby leading to increase in RBF and GFR. So, I'm actually missing a few slides here. Just give me a moment. I had two PPTs for the same topic, so I think that there's been a bit of an exchange. Okay. Yes, so sorry, couple of slides were missing. This is the one where I just talked about the hormonal regulation just a moment before this slide, where I told you certain hormones, they cause vasoconstriction and decrease of RBF and GFR. So I talked about norepinephrine and angiotensin II, both causing constriction of afferent and efferent arterioles and even endothelium. And then I told you about hormones which cause vasodilation and thereby increase of RBF and GFR. So those are the prostaglandins, nitric oxide, bradykinin, ANP, glucocorticoids, dopamine, and histamine. So this table shows you their list and what are their effects on GFR and RBF. This was the nervous regulation we talked about. Then a little bit that you should know about measurement of renal blood flow. What are the methods? So it can be measured by electromagnetic flow meter, okay? And the principle is that when a vessel containing blood, which acts as a conductor, is placed between two poles of a magnet, the voltage generated in blood flowing through magnetic field and magnitude of voltage is proportional to the volume of flow and can be measured with a appropriately placed electrode on the surface of vessel. Okay, so this is one method of measurement of renal plasma flow through an electromagnetic flow meter. The second method is through something called as a para-amino hippuric acid clearance or PAH clearance. Again, I would say don't worry about this because when in later chapters we talk about clearance, again you will go through this topic again. Then, okay. So basically, secretion of para-amino hippuric acid occurs into tubular fluid via carriers in the PCT by a transport maximum limited process, and the TM of PAH is about 80 milligram per minute. So when the PPAH is low, the para-amino hippuric acid is almost completely cleared from plasma by a combined process of filtration and secretion. When it is above 20, then transepithelial secretory process is saturated and TM of PAH is reduced. Then quantity of PAH secreted remains constant and independent of PPH. And once the transport maximum of PAH is reached, the clearance becomes progressively more of a function of glomerular filtration. Okay, and PAH secreted becomes a smaller fraction of total amount excreted. Because Tm of pH is nearly constant, it is used clinically to estimate tubular secretory capacity. So I know that this would not be very clear at this point, so don't worry about it, because when we talk about clearance little later on, you will understand. Right now, I think at this point, it's just enough to know that there are two main methods of measurement of renal plasma flow, through an electromagnetic flow meter and through the PAH clearance method, okay, which this is something we'll read about later again, several times through this unit. So it's basically the ratio of GFR to renal plasma flow. It can be measured indirectly from filtration fractions. At normal values of GFR, which is 125 milliliter per minute, and RPF, which is 650 milliliter per minute, your filtration fraction is 0.2. Okay, so 125 upon 650. So normally only 20% of renal plasma flow is actually filtered per minute. Okay, so that's all for this unit, for this lecture. Are there any doubts or queries? Anything you want me to revisit? Or we can end the session if, please let me know. Yes, feel free to unmute yourself and ask any queries, or if you want me to go back to any slide. Or would you like me to end the session now? In any case, if some questions and doubts come to you later on, feel free to send them to your CR and she can forward them to me. I'll be happy to get back to you on them. Okay, so it's 5 minutes to 1. If you all are fine, then we can end the session. Okay, so since I am not getting any response, I think we'll call it a day. And as I said, just forward your queries and I'll be happy to answer them.